5 years ago, we lost our minds and launched what is probably one of the largest, if not the largest, Spanish project, and for sure one of the largest European projects in the field of monoclonal gammopathies of undetermined significance, or MGUS. I should start by saying that MGUS is a condition that is usually benign, but very frequent, probably more than 5% of people aged over 60, meaning that in this aging population at the European level, there will be millions and millions of individuals with MGUS. So 5 out of 100 people aged over 60 will receive during their lifetime a diagnosis of something of undetermined significance. And we thought that enough is enough, and it doesn't make any sense that so many European citizens are being diagnosed with something of undetermined significance. This creates confusion, this creates anxiety, not only to the person that has an MGUS, but also to their families. And I believe that the time is now to develop the tools and the methods to clarify the undetermined significance of MGUS. So we don't want to change the name, or maybe we do, but we do want to subclassify MGUS into those of no clinical significance, that will be the vast majority, for whom those individuals do not need frequent visits to the hospital, not alone frequent lab tests, some of them invasive, and then to identify those few gammopathies that may be of clinical significance. This is already out there because there are a couple of monoclonal gammopathies of clinical significance that have already been identified and even lead to treatment initiation. For example, monoclonal gammopathy of renal significance. Now, what we want to offer from the laboratory point of view is the possibility of identifying 2 monoclonal gammopathies of clinical significance. One associated with malignant transformation to myeloma, light chain amyloidosis, and lymphoplasmacytic lymphoma. The other one is associated with infection. Why these 2? Because historical data from the Mayo suggests that individuals with MGUS, despite being a benign condition in most, do not have the same overall survival as those without MGUS. It's slightly inferior. And the 2 main drivers of the inferior survival or increased mortality are, number 1, malignant transformation to an incurable cancer, such as myeloma or AL or Waldenström's. Secondly, a higher chances of developing severe infections that may lead to some morbidity and mortality. So we believe that we have the tools in the laboratory, particularly from the flow cytometry point of view, to add a missing element to staging criteria, that is circulating tumor cells, and to develop high-resolution immune profiling to identify individuals with a less fit immune system that may be at higher risk of severe infection and for whom prophylaxis would probably be beneficial. And we are showing for the first time, so the project was initiated in 2021-22. It aims at enrolling 5,000 MGUS individuals in Spain that are being monitored every year during 5 years. This means approximately 25,000 samples. It's a massive project, and we need the support and help from everyone that would be willing to support us in this crazy initiative that mainly aims at defining monoclonal gammopathies of no clinical significance that are completely benign to reduce or avoid anxiety. As I said, at this ASH we are presenting for the first time ever the first interim analysis of the study on the first 1,000 patients that were enrolled, and we have very interesting data about the potential, the added value, the complementarity that CTCs, circulating tumor cells, offer to other more classical biomarkers. And the data, I think, is promising enough to make us dream that indeed we'll be able to define a monoclonal gammopathy of no clinical significance based on the kinetics over time of CTCs as well as other biomarkers. The methods are already there, are implemented. In fact, they serve for other purposes, such as MRD assessment or screening of clonality. Being in Spain, we try to do our projects very realistic, very cost-effective. The resources are limited, and we want to make it global. We want to develop biomarkers that can be applicable worldwide. So this has clear potential to be applied in routine practice soon, if not immediately.